So the thyroid produces two active hormones whose synthesis is stimulated by a low plasma level of iodine. And if you remember from patho, that's a feedback system from the pituitary. So the first hormone is the triiodothyronine, T3, and the synthetic form is called um, liothyronine. The other is thyroxine, which is T4, and its synthetic formulation is a levothyroxine. It's important to know that T4 is always converted to T3 to be utilized by the body. So what tests do you perform to measure the thyroid hormones? You first would measure a TSH. That's usually what you're going to use as your screening and diagnostic for hypothyroidism, because an elevated TSH is an indicator for hypothyroidism. So normally in practice, you're going to find that if you just need to order one test to check a person's thyroid, whether routinely or while they're starting or on medication, it's going to be the TSH. Then you can measure a T4. A T4 measures the total or free um, thyroid T4 hormone, and then you can also do a T3. Normally, if I have to add another test, I will add a T3 or a free T3 because that tells me how much of the thyroid hormone of the T4 is circulating in the body. So many times besides the TSH, you will get a free T4 to see how much is actually circulating in the body. So with hypothyroidism in adults, the clinical presentation, you have the pale puffy face, the skin is cold and dry, the hair will be brittle or they may complain of loss of hair. They usually have a lower heart rate and temperature. There can be lethargy and fatigue, and intolerance to cold, impaired mental status, and some patients do gain weight. I know you're going to hear patients will say, "Oh, check my my thyroid because, I have this weight and I can't get it off." Well, yes, we do find with hypothyroidism that patients' metabolism may be slower, but that usually is not the cause of much of their weight gain. If it's a significant weight gain, then we're looking at an endocrine problem that is more involved than just having hypothyroidism. Causes is usually due to a malfunction of the thyroid. There's Hashimoto's disease, which is a chronic autoimmune thyroiditis. You can have insufficient iodine in the diet. Now, that's very rare here, of course, in the United States. If you have surgical removal of the thyroid or destruction of the thyroid with the radioactive iodine, and then if there's insufficient secretion of TSH and the TRH. So how do we treat hypothyroidism in the adult? There is a therapeutic strategy that's used, and it's lifelong replacement of through levothyroxine with T4 or with the liothyronine, which is T3. And if you remember, the T4 has to be converted to T3 to be active in the body. So T4 is converted to T3. So when you give the levothyroxine, it converts within the body to T3. Hypothyroidism lifespan issues. During pregnancy in the first trimester, it can result in permanent neuro psychologic deficits in the child. So it's very important that this is usually checked on that first prenatal visit. And in infants, um, the damage may be permanent or transient. It can cause mental retardation or derangement of growth. So when children are born, when they have that newborn panel done, that is part of it to check for any hypothyroidism so that the infant can be placed on medication right away. Now we'll move on to hyperthyroidism. There are two forms. One is Graves' disease, which is the most common, usually affects women 20 to 40, and it causes the exophthalmos. So you'll see where the eyes appear to be basically almost like bugging out. Um, what's always interesting to me is that how women can have that start to happen, and it's almost like they don't notice it because when they come in and they complain of their symptoms, you look at them, and that's one of the things you can see right off if it's already started to happen, and they don't seem to have noticed that their eyes may gone through that change. The other is a toxic nodular goiter called plumber's disease, which is less common. Um, Causes of hyperthyroidism are your thyroid stimulating immunoglobulins are altered. So what is the treatment? You can have surgical removal of the thyroid tissue. You can have destruction of the thyroid tissue with the radioactive iodine. You can have suppression of the thyroid hormone synthesis through medications. You take beta blockers such as propranolol, but that's for the symptoms of the rapid heart rate. And you can also use non-radioactive iodine. What is a thyrotoxic crisis or thyroid storm? Patients with thyrotoxicosis who undergo significant stress, um, usually like surgery or illness, it's not triggered by any change in the hormones, and you can't identify it through laboratory testing of the TSH, T3, or T4. So how do you do that? Well, the signs are pretty significant. You're going to have hyperthermia with a temp of 105 or higher, severe tachycardia, restlessness, agitation, tremor, unconsciousness, coma, hypotension, heart failure. The other problem, so then what is the treatment? Uh, you can have methimazole, you can do beta blockers, you would want sedation, cooling, corticosteroids, IV fluids to treat the other signs. So now we're going to talk about the thyroid hormone preparations. The first preparation, the most common for hypothyroidism, would be the levothyroxine and trade name Synthroid. It is a synthetic preparation of T4, and it is usually the drug of choice with the conversion to T3, which is then utilized by the body. It has a long half-life of 7 days, and is used for all forms of hypothyroidism. That long half-life means that you have to wait. When you want to check new levels after changing the preparation, you would have to wait sufficient time to get your labs redrawn. One thing that's important with your thyroid preparation is that it should be taken in the morning at least 30 to 60 minutes before breakfast. It a lot of other meds that you take can affect the absorption, and it's very important that you get all of this medication, because what are you doing? You're usually many times replacing the body's hormone totally if you don't have one. I've had mine removed, and it's important that I remember to take it first. So I usually tell my patients to I put the pill by the bedside, um, either the bottle to remind me as soon as I wake up, it's sitting right next to the bed, or if you want to sit it next to your toothbrush, whatever will make you remember before you do anything, before you eat any food in the morning, that you have taken that pill. So if they can get in the habit of taking it as soon as they wake up at the bedside, by the time they get up and get dressed, that 30 minutes is easily passed, and then they can eat breakfast, or eat breakfast on the way out. What are some adverse effects of the medication? You can have tachycardia, that's angina, tremors, and it can intensify the effects of warfarin. So you have to be careful with patients on warfarin. Now, with all these side effects, it's usually because the dose will probably have to be adjusted. So they should not be experiencing any of these things on a regular basis. But if the dose is too high, then that is certainly common. And when you first put a patient on it, you're doing it, especially if they've had their thyroid removed, you're doing it based on their weight. So many times it's higher. When I first started, I was like at 125 mics, and I think we even went up to maybe 137 at one point in the very beginning. And now I fluctuate between 75 and 100. It kind of goes back and forth. But I've never been on the starting dose again. What are drug interactions besides the warfarin? You have any drug that can reduce the levothyroxine absorption, drugs that accelerate the metabolism, and catecholamines. So this is where your drug guides, Hippocrates, um, whichever drug book you tend to use, will have listed all of the interactions. And because of that, that's why taking it 30 minutes before you take anything else will help avoid having those other interactions, even with food, which could delay the absorption. You have other thyroid preparations. You have the Levotrex, and you have the Armor Thyroid, which is a natural preparation. Armor Thyroid is actually um, from the pig. It's a natural preparation and not synthetic. So many patients like to have natural preparations of their thyroid. Um, that is fine. They don't always tend to work as well, but if a patient can't tolerate levothyroxine for any reason, especially if they're having a lot of cardiac issues, many times they can tolerate the Armor Thyroid. And Armor Thyroid has T3 and T4. You do have to make sure with those preparations, since it is a from a live animal pig, that the patient has no um, religious or cultural um, issues with having that thyroid preparation. So they need to be made aware of that before you would prescribe it, if it's something that you like to prescribe for patients. Okay, with hyperthyroidism, methimazole is the first line drug for hyperthyroidism. Um, it does not cause the liver damage associated with PTU, which can also be used. It does not destroy the existing stores of thyroid hormone. It can take 3 to 12 weeks to get a euthyroid state, so that's a little while to have to watch the patient, especially you're watching for any thyroid storm or the patient just not feeling well. Um, More dangerous than PTU during lactation and during the first trimester of pregnancy. So during pregnancy in the beginning, and if they want to breastfeed, you'll have to use a PTU instead. One of the big side effects, of course, though, is agranulocytosis. So you use the methimazole for, it is a therapy for Graves' disease. You can use it as an adjunctive to radiation until the radiation um, effects manifest themselves. You can use it to suppress the thyroid hormone in preparation for the surgery, and you can use it in a toxic crisis. Then we have the PTU, and it inhibits the thyroid hormone synthesis. It's the second line. Has a short half-life of only 90 minutes. Full benefits for this can take 6 to 12 months, which is a very long time. And it's used for Graves, adjunct to radiation, again, preparation for surgery, for the thyroid crisis, thyrotoxic crisis. Adverse effects, the agranulocytosis for this one also, which is the most serious. Hypothyroidism, once it destroys the thyroid gland. You do not want to take this in pregnancy. We just discussed not in the first trimester or during lactation. This is where you'll use a methimazole instead, and it can cause severe liver damage, which you did not have also with the methimazole. So that might be another reason why you would pick methimazole. So this slide just talks about those differences in how they work. So you can read that over. And next we have radioactive iodine, which is the radioactive isotope of stable iodine. Half-life is 8 days. It can take 2 to 3 months for the full effect. That's why you might need to supplement with medication. It is used in Graves' disease. Um, it can be used in thyroid cancer, um, and there's many different preparations for that. There's a non-radioactive iodine, um, Lugol's solution. It's a strong iodine solution. It can suppress function in preparation for the surgery. It has some side effects such as a brassy taste, burning sensation in the mouth and throat, soreness of the teeth and gums, frontal headache, um, skin eruptions. So patients won't like this preparation, but if they don't want to have any radiation, this could be an alternative while they're waiting for surgery. Next, we have beta blockers, and this is the last one. The beta blockers are used to suppress the tachycardia. I mentioned that earlier with the symptoms of Graves' disease. Um, so it's beneficial in that thyrotoxic crisis because, again, it helps with the tachycardia. So now we have a few questions. The nurse instructs the patient about taking levothyroxine, which is Synthroid, which indicates teaching has been effective. And the answer is B. If I have chest pain or insomnia, I should call the doctor, which is exactly right. We talked about the angina that can be possible. We know we don't want to take that within an acid. That would delay absorption, interfere with absorption. It should be taken in the morning, 30 minutes to 60 minutes before a meal, breakfast, so it's not at nighttime. And you should not take it with food, of course. Question 2, patient with hyperthyroidism is taking PTU. What's the most important to assess for adverse effects? And you've got to think what the adverse effects are. So the answer would be D, because the most serious side effect is agranulocytosis, and sore throat and fever are symptoms, early symptoms of agranulocytosis. Question 3, patient takes levothyroxine Synthroid 0.75 micrograms every day. What is the most appropriate for the nurse to monitor? Which lab? And that is, of course, B, TSH. That is your most common indicator and measurement for hypothyroidism. Like I said, if you added something to, it would be a free T4, but you would always get your TSH with that. And that is it for our lecture today. Thank you.